Hello and welcome to Caring for the Child with Heart Disease. This is under the concept of perfusion. This is for NUR PNR 180 and my name is Judy Locray. So before you go any further, I want you to go back to your Moodle page and I want you to watch the two videos that I posted on the anatomy and physiology of an adult heart and the anatomy and physiology that occurs in fetal circulation. Once you do that, I want you to come back and I want you to listen to this video because it will help you to understand some of the defects that can occur once a child is born. And you'll understand, oh, I get it. This is why this might have happened, or this might be why this might have happened, or that. But in fetal circulation, a baby cannot breathe in air. They're in the mother, so their nutrients are being supplied to them by the placenta. The placenta typically has an umbilical vein, 1, and 2 umbilical arteries. There are also some types of shunts that occur. One is called the forum ovale. The forum ovale is a shunt or a duct that exists between the fetal atria. The ductus arteriosus, which connects the pulmonary artery and the aortic arch. And a ductus venosus, which is a fetal structure that is part of the umbilical vein that empties into the inferior vena cava, diverting blood flow or a significant amount of blood flow to the liver. Here is a picture of what you might see in the changes at birth that occur in a child from a fetus to a child. So you'll see right here is the ductus venosus. That is the shunt that shunts blood from the liver. The ductus arteriosus between the aortic arch and the pulmonary artery, and the forum ovale, which has an opening or connection between the right atria and the left atria. And as you see, once the child's born, hours, days, or weeks, depending on which structure you're referring to, you'll see that this closes up or becomes ligature right here and between here, and the pressure of the left atria and the right atria, the left is greater than the right, which pushes the wall or the forum ovale to close, and that usually happens within minutes after birth. The others may happen within days or weeks. Okay, so let's do an overview of heart disease, congenital or acquired. Congenital is an anatomic problem. It results in abnormal functioning. So defects with increased pulmonary blood flow, which can be a ventricular septal defect, abbreviated VSD, atrial septal defect, which is abbreviated ASD, atrioventricular canal defect, and patent ductus arteriosus, which is also abbreviated PDA. Obstructive defects can also be a congenital anatomic defect. Those would be, examples of that would be coarctation of the aorta, aortic stenosis, and pulmonic stenosis. Defects with decreased pulmonary blood flow, such as tetralogy of Fallot and tricuspid atresia. Mixed disorders, such as transposition of the great vessels, and total anomalous pulmonary venous connection, or truncus arteriosus, and hypoplastic left heart syndrome. So, it can be acquired as well, heart disease. So, acquired usually is infectious. One big example that we'll be talking about is rheumatic fever or rheumatic heart disease. Also, it can be inflammatory autoimmune, which we would also talk to, and that's an example is Kawasaki's disease. It also can be environmental or familial. So environmental exposure to chemicals can cause sometimes a heart defect, or there is an increase in incidence of CHD if it occurs in a sibling or a parent. So causes of congenital heart disease. Chromosomal genetic defect is in about 10 to 12% of the cases, and maternal or environmental is in about 1%. So more causes of congenital heart defect or congenital heart disease. So maternal illness, infections such as rubella. Rubella is also known as German measles, and oftentimes they'll do tests to make sure that you have the immunity to German measles. when you get the mumps, measles, and rubella vaccine. That includes the vaccine against rubella. 50% of heart defects can result from rubella, including patent ductus arteriosus. Also, some other infections, such as cytomegalovirus, toxoplasmosis, and other viral illnesses can lead to cardiac defects. Chronic illnesses, such as uncontrolled diabetes or PKU, which is phenylketonuria, maternal drug and alcohol use and exposure to toxins, familial history, chromosomal abnormalities and specific syndromes, and also multifactorial. There could be multiple things that they were exposed to some type of infection, had some type of chromosomal anomaly, maybe had some family history. So one thing to note, if a parent or sibling has had known congenital heart anomaly, the risk is about 3% for a sibling to have it, and can increase to up to 10% in siblings for hypoplastic heart disease. Chromosomal anomalies that often have CHD affiliated with it include trisomy 21 with Down syndrome, trisomy 18 or Williams syndrome, Noonan syndrome and DeGeorge syndrome, and that's just to name a few. So there are different types of syndromes that you might see. The incidence is about 5 to 8 per 1,000 live births. It's a major cause of death in the first year of life. The most common anomaly that you'll see is ventricular septal defect, and 28% of kids with CHD have another recognized anomaly. So classifications. The reason that I'm telling you about older classifications is because sometimes you will still hear people discuss that they have acyanotic or cyanotic CHD. With an acyanotic type of disease that they describe, eventually they may become cyanotic, and with cyanotic they may develop congestive heart failure. So in clinical practice, this classification has become a problem because eventually patients with acyanotic CHD became cyanotic, and those with cyanotic CHD sometimes appeared pink, so it got confusing as to the classification. But again, the reason that we mention it here is because sometimes you will hear practitioners refer to that once in a while. So the newer classification that makes more sense is based on the hemodynamic characteristics or blood flows within the heart. So what that means is that we classify the diseases if they produce increased pulmonary blood flow. We'll classify another group that might include decreased pulmonary blood flow. We have some that are obstructive of blood flow out of the heart, and then there are some that have mixed blood flow. So in an example of a CHD, or congenital heart disease, with increased pulmonary blood flow will include atrial septal defect, ventricular septal defect, atrioventricular septal defect, and patent ductus arteriosus and tricuspid atresia. So an example with decreased pulmonary blood flow would be tetralogy of Fallot. An example with obstructed blood flow would be such as coarctation of the aorta, or aortic or pulmonic stenosis. An example of mixed would include something like the transpositions of the great vessel or hypoplastic left heart syndrome. So those are some examples. So with that, we're going to discuss in each category some specific diseases that occur with them, or problems or defects. So increased pulmonary blood flow defects. What we see with this is an abnormal connection between the two sides of the heart. So we know just by looking at the prenatal that can occur very easily if that normal form of LA doesn't close, correct? So what we see when the person's born is a normal connection between the two sides of the heart. So either the septum or the great vessels are affected. So again, the PDA could be affected as well. Increased blood volume on the right side of the heart because the pressure is greater on the left, pushing the blood over to the right. Increased pulmonary blood flow and decreased systemic blood flow. So there is a left to right shunting within the heart, which leads to heart failure in those children with increased pulmonary flow defects. So increased pulmonary flow defects include atrial septal defect, ventricular septal defect, Atrioventricular canal defect in patent ductus arteriosus. So atrioseptal defect. This is when there's an abnormal opening between the atria. So as you can see in this picture right here, I'm hoping that is showing up. See that where the arrows, there is an opening between the two atrias. That's an atrioseptal defect. Now, of course, that looks like the forum ovale, which hasn't closed. However, it does not necessarily have to be the lack of closure of the forum ovale. There can be other types of problems with the atrioseptum. So there are three types. The first one is ostrium primum, which is ASD1, and that's an opening at the lower end of the septum, and it could have some mitral valve abnormalities occurring with it. There's also one called the ostium secundum, which is an ASD2, opening near the center of the septum. And there's one called the sinus venous defect, which is an opening near the junction of the superior vena cava and the right atrium, and it may be associated with partial anomalous pulmonary venous connection. So this opening allows blood from a higher pressure, the left atrium, to flow into an area of lower pressure, the right atrium. So cardiac failure is unusual, an uncomplicated ASD, but pulmonary vascular changes usually occur after several decades if the defect is left untreated. So clinical manifestations of someone with ASD, they may be asymptomatic depending on how large this particular hole or duct is or opening. Usually there's a characteristic systolic murmur with a fixed split second heart sound. There also may be a diastolic murmur. And emboli formation later in life can occur if left untreated due to increased pulmonary blood flow. These patients, depending on the extent of the opening and damage, may or may not develop heart failure. Treatment. So the treatment of someone with an ASD is a surgical patch, could be a pericardial or Dacron patch, and it's usually done for large defects. And typically this is done for the child prior to starting school. There's also non-surgical treatment, which is closure with a device through the cardiac catheterization, such as with a septal occluder. That's obviously for smaller defect. Patients are typically receive low-dose aspirin for 6 months. And the prognosis is after surgery is less than 0.5%, so it's pretty good. So depending on the type of ASD that is present, the child may or may not need mitral valve repair. Because remember, in some cases, mitral valve is involved, and in others, it may not be involved. So the next defect we're going to talk about is ventricular septal defect. So that is an abnormal opening between the right and left ventricles. So we know the ASD is between the atria, a VSD is between the ventricles. So this varies in size. It can be from a tiny pinhole to the absence of a septum. It can be membranous or muscular. So 20 to 60% close spontaneously during the first year of life, and it's often associated with other congenital cardiac defects such as pulmonary stenosis or transpositions of the great vessels. So there is a higher pressure within the left ventricles, and the systemic circulation offers more resistance than the pulmonary circulation, so the blood flows through the defect into the pulmonary artery. Increased blood flow is pumped into the lungs, which may result in increased pulmonary resistance. So there is an increased pressure in the right ventricle as a result of left to right shunting and pulmonary resistance, which causes the muscle to atrophy. If the right atrium is unable to accommodate the increased workload, the right atrium may also enlarge. So you're going to see a multiple type of defect occurring if this isn't repaired or if it doesn't repair within itself. So clinical manifestations of someone with a VSD, heart failure can be common. There's a loud systolic murmur. It's best heard over the left sternal border. Patients are at risk for pulmonary vascular obstructive disease. So normally the left side of the heart only pumps blood to the body, and the heart's right side only pumps blood to the lungs. And you remember that, and if you watch Khan Academy, it will review that for you. When a large opening exists between the ventricles, a large amount of oxygen-rich or red blood from the heart's left side is forced through the defect into the right side. This blood is pumped back to the lungs, even though it has already been refreshed with oxygen. So unfortunately, this causes the heart to pump more blood. The heart, especially the left atrium and the left ventricle, will begin to enlarge from the added work. High blood pressure may occur in the lungs and the blood vessels because more blood is there. So over time, this increased pulmonary hypertension may permanently damage the blood vessel walls. When the defect is small, not much blood crosses the defect from the left to right, and there's little effect on the heart and lungs. The patients experience difficulty breathing and rapid breathing usually. So what is the treatment? Treatment, if it's a small defect, it may close on its own. Palliative treatment is pulmonary artery banding, placement of a band around the main artery to decrease pulmonary blood flow. They can also do a complete repair. Small defects are repaired with sutures. Larger defects are repaired with a Dacron patch. Prognosis is dependent on the size of the defect and whether associated with other heart defects. The next defect that we're going to discuss is called the atrioventricular canal defect, or AV canal defect. This is incomplete fusion of the endocardial cushions. What it consists of is a low ASD and a high VSD. There are large clefts of the mitral and tricuspid valves. Blood flows through all chambers. This direction of blood flow is determined by the pulmonary and systemic resistance. It's generally from left to right. It is the most common defect in children with Down syndrome. So if you look at a healthy heart here over on the left, there's septum walls and there's valves working. Everything's working beautifully. But with someone with atrioventricular defect, you look at the septums, there's a low ASD and a high VSD. Blood is intermingling throughout the heart, and that is it is not conducive for life, essentially. So what do? What are some of the clinical manifestations of AV canal defect? We see a loud systolic murmur, here. Heart failure. Mild cyanosis that increases with crying. Patients are at risk for developing pulmonary vascular obstructive disease. How do we treat? So treatment may be palliative initially. Pulmonary artery banding is sometimes done with small infants to help suppress the symptoms until they're well enough to have a surgical repair. So surgery is complete repair, which consists of patch closure of the septal defects and reconstruction of the AV valve tissue. The prognosis is good after surgical repair with only a 3 to 10% mortality rate. Complications that may occur later are hypoplasia or left ventricular and AV valve regurgitation. The next defect that we're going to talk about is called a patent ductus arteriosus, or PDA. This is failure of the fetal ductus arteriosus. Remember that artery that's connecting the aortic arch to the pulmonary artery? To close within the first weeks of life. It causes left to right shunting of the blood. So before the baby is born, the fetus blood does not need to go to the lungs to get oxygenated, remember? So the ductus arteriosus is that hole that allows the blood to skip the circulation to the lungs. However, when the baby is born, the blood must receive oxygen in the lungs, and this hole is supposed to close. If the ductus arteriosus is still opened or patent, the blood may skip this necessary step of circulation. That open hole is what is referred to as a patent ductus arteriosus, and you can see it right here. Okay. Clinical manifestations of PDA. The patient may be asymptomatic. They may show signs of heart failure. There's a characteristic machine-like murmur. So that murmur that you might want to see if you can Google that sound on YouTube. Or I'm hoping that in Sims you can schedule a time maybe to go, well, if you're allowed on campus, to go and listen in Sims to see, to hear that particular machine-like murmur. There's also a widened pulse pressure and bounding pulse. Patient is at risk for bacterial endocarditis and pulmonary vascular obstructive disease in later life. treatment, medical management, the administration of prostaglandin inhibitors, such as with the medication indomethacin, has proved successful in closing a PDA in preterm infants and some newborns. So one thing to remember, and when you watch the Khan Academy or you rewatch it to review the fetal circulation, is that the placenta also helps to produce prostaglandins that keep that duct arteriosus open. So if we administer prostaglandin inhibitors, it helps to keep that opened. Does that make sense? It helps to, inhibitors help to close off the PDA. So they also will do surgical division or ligation of the patent vessel, which is performed via thoracotomy. They will do a thoracoscope, sometimes used with a video camera to use minimal invasive surgical techniques through a thoracoscope. So the instrument is inserted and a clip is placed on the ductus. So non-surgical treatment, they might use coils to occlude the PDA, and that's placed via cardiac catheterization. Prognosis is good. The mortality rate is almost 0%. So we've just discussed defects that would increase pulmonary blood flow. Now let's discuss defects that produce decreased pulmonary blood flow. Those include tetralogy of Fallot and tricuspid atresia. So tetralogy of Fallot in the classic form includes 4 defects. So it includes first, a ventricular septal defect. Remember what a ventricular septal defect is: a communication or a defect in the septum between the 2 ventricles. Pulmonary stenosis. Well, when you think of stenosis, that is a narrowing of the pulmonary vein. Overriding aorta and right ventricular hypertrophy, which is an enlargement of the right ventricle. Clinical manifestations of tetralogy of Fallot. There's a mild cyanosis, which progresses as PS progresses. There's a systolic murmur. They may have cyanotic episodes like blue spells and anoxic spells where oxygen requirement exceeds blood supply. So the O2 saturation drops that requires supplemental O2. Patients are at risk for emboli and seizures after anoxic spells. So you'll see sometimes children with tetralogy of Fallot are often seen squatting. Squatting is a compensatory mechanism of diagnostic significance and highly typical of infants with tetralogy of Fallot. Squatting increases peripheral vascular resistance and thus decreases the magnitude of the right to left shunt across the ventricular septal defect. Treatment of tetralogy of Fallot. Palliative shunting is done for infants not able to undergo surgery, which helps provide blood flow to the pulmonary arteries. Surgery for complete repair, usually completed during the first year of life. The prognosis, operative mortality rate is less than 2 to 3% during the first 2 years of life. And I think this is one that Jimmy Kimmel's child had, the tetralogy of Fallot. The next particular heart defect with decreased pulmonary blood flow is the tricuspid atresia. So a tricuspid atresia, this is the tricuspid valve fails to develop, and therefore there is no communication between the right atrium and the right ventricle. Blood flows through an ASD or a patent ovale to the left side of the heart and through a VSD to the right ventricle and out the lungs. So there's a mixing of unoxygenated and oxygenated blood, which occurs, causing desaturation. Some pulmonary obstruction occurs, resulting in decreased pulmonary blood flow. Clinical manifestations of tricuspid atresia: cyanosis, tachycardia, dyspnea, And in older children, you may present with signs of chronic hypoxia and clubbing of the fingers and nails. Treatment of tricuspid atresia is palliative, placement of a shunt to increase blood flow to the lungs. Surgery, surgical repair using a modified Fontan procedure that separates oxygenated and deoxygenated blood inside the heart and eliminates excess volume load on the ventricles. Prognosis, surgical mortality is less than 3%. In some cases, children with tricuspid atresia have increased pulmonary blood flow. So just so you know that this is classified as a decreased, but in some cases, these children may have increased pulmonary blood flow. And in that case, what they do is arterial banding to lessen the volume of blood flow to the lungs. But typically, blood flow with someone with tricuspid atresia have decreased pulmonary. Conditions or defects that cause obstructive defects of the heart consist of coarctation of the aorta, aortic stenosis, and pulmonic stenosis. Coarctation of the aorta is a localized narrowing near the insertion of the ductus arteriosus, resulting in increased pressure proximal to the defect, where the head and upper extremities, and decreased pressure distal to the obstruction, the body and lower extremities. Clinical manifestations, you're going to have a high BP and bounding pulses in the arm, excuse the typo, weak or absent femoral pulses and cool extremities with lower BP in the lower limbs. Older children may experience dizziness, fainting, headaches, and epistaxis. And patients are at risk for hypertension, ruptured aorta, aneurysm, and stroke. Treatment of coarctation of the aorta surgery is the treatment of choice. Usually surgical resection with end-to-end anastomosis of the aorta. Sometimes grafts are used to enlarge the constricted area. Non-surgical repair consists of balloon angioplasty. And in non-surgical repair, it's usually used for reoccurrence after surgical procedure. Aortic and aortic valvular stenosis is narrowing or stricture of the aortic valve, causing resistance to blood flow in the left ventricle. Clinical manifestations of aortic stenosis is decreased cardiac output resulting in faint pulses, hypotension, tachycardia, and poor feeding. Children have signs of exercise intolerance, chest pains, and dizziness when standing for long periods. Systolic ejection murmur is often present. Treatment of aortic stenosis is surgical. They will do an aortic valvotomy, enlargement of the valve, or valve replacement. The prognosis is good, but repeat valvotomy and additional surgery is sometimes required within 10 years after surgery. Pulmonic stenosis. So pulmonic stenosis is narrowing of the entrance to the pulmonary artery. Resistance to blood flow causes right ventricular hypertrophy and decreased blood flow. So as you can see, there's a stenosis in the pulmonary artery. Clinical manifestations of pulmonary stenosis. Patients may be asymptomatic. Some may have a mild cyanosis. Some may have heart failure, and you'll hear a loud systolic ejection murmur. Treatment for pulmonic stenosis is surgery, a valvotomy. Non-surgical repair is a balloon angioplasty. Prognosis is good. Mortality rate is less than 1%. Mixed defects of the heart include transposition of the great vessels and hypoplastic left heart disease. There are other mixed types of heart defects we're not going to review all of them. I don't expect you to have everything memorized, but to just have a general idea of that. But those would include total anomalous venous connection and truncus arteriosus. So let's talk about transposition of the great vessels. This is a condition where the pulmonary artery leaves the left ventricle and the aorta exit the right ventricle with no communication between the systemic and pulmonic circulation. Clinical manifestations and treatments of transposition of the great vessels. You'll see severe cyanosis. Cardiomegaly may occur a few weeks after birth. So treatment, management with IV prostaglandins, E1, to keep the PDA open to help increase blood flow, keeping saturation at 75%. So remember, they have severe cyanosis. Remember, with patent ductus arteriosus, we wanted to close that duct if it was kept open, and we use medication that inhibits prostaglandins. For someone with the transposition of the great vessels, we want to increase the blood flow in that area, so they will try to keep that duct or the PDA open, and they will do that by administering prostaglandins to keep it open. Surgery, an arterial switch procedure, is also what they do. Coronary arteries are switched from the proximal aorta to the proximal pulmonary artery to create a new aorta. The prognosis varies as to the extent of the defect post-surgery. Usually, mortality is less than 6%. The next defect that we'll talk about, which is a mixed type, is hypoplastic left-sided heart syndrome. This is underdevelopment of the left side of the heart, resulting in hypoplastic left ventricle and aortic atresia. The clinical manifestations and treatment of a hypoplastic left heart disease or heart syndrome. Clinical manifestations is mild cyanosis and heart failure. After the PDA closes, symptoms progress. Condition is fatal the first month of life without intervention. So there's a multi-stage surgical approach. Stage 1 is a Norwood procedure, which is an anastomosis of the main pulmonary artery to the aorta with the creation of a large ASD. Stage 2 is a bidirectional shunt, shunting blood to bypass right atrium directly to the lungs. And stage 3 is a modified Fontan procedure, which directs systemic venous return to the lungs without a ventricular pump through surgical correction of the right atrium and pulmonary artery. Oftentimes, these particular children who are born with hypoplastic left heart syndrome need a heart transplant in order to live. The prognosis is improving and varies widely, and some facilities report mortality rates post-intervention at 10%. Those are some of the defects that are not commonly seen, but more commonly seen in children or in newborns, and that occur most frequently if they're going to occur at all. So with that, we need to understand heart failure in children. Heart failure is the inability of the heart to pump adequate amount of blood to the systemic circulatory system at normal filling pressures to meet the body's metabolic needs. Heart failure in children most frequently occurs secondary to structural abnormalities, which is what we just spoke about. So let's do the classification of heart failure. Right-sided heart failure, the right ventricle is unable to pump blood effectively into the pulmonary artery, resulting in increased pressure in the right atrium and systemic venous circulation, leading to systemic venous hypertension, hepatosplenomegaly, and edema. Left-sided heart failure, the left ventricle is unable to pump blood into the systemic circulation, resulting in increased pressure in the left atrium and pulmonary veins. The lungs become congested with blood, causing elevated pulmonary pressure and pulmonary edema. It is unusual to observe right or left-hearted heart failure solely in a child because each side of the heart depends on the adequate function of the other. General pediatric indicators, cardiac dysfunction and heart failure. So when we see impaired myocardial function, we see tachycardia and restlessness. sweating, anorexia, fatigue and weakness, pale, cool extremities, weak peripheral pulses, decreased blood pressure, and decreased urinary output. PD indicators of cardiac dysfunction and heart failure. We see pulmonary congestion, tachypnea, dyspnea, respiratory distress, which is retractions, nasal flaring, grunting, and wheezing, a hoarse cough, exercise intolerance, and cyanosis. PD indicators continued systemic venous circulation, congestion. So we'll see peripheral and periorbital edema. We'll see weight gain, ascites, hepatomegaly, and neck vein distension. Also, we will start to see failure to thrive, decreased activity, developmental delays, positive prenatal history we're going to assess for, and positive family history of cardiac disease. So let's do an NCLEX style question. A 3-week-old infant is admitted with a heart defect. Which assessment findings should be discussed with the physician? Select all that apply. So we have heart murmur, dyspnea, weight gain of 0.5 kilograms, apnea, or heart rate of 154. If you chose dyspnea and weight gain of 0.5 kilograms, you are correct. So apnea is a normal breathing pattern, and heart rate of 154. This finding can also be normal in a newborn, and oftentimes there is a heart murmur present initially in the infant and child that can be benign. Here's an explanation of the previous slide. So how do we diagnose these conditions, heart failure? EKG, ECG, EKG, chest x-ray, echocardiogram, cardiac catheter, and cardiac MRI. You know, an EKG is an electrocardiogram that measures the electrical activity of the heart. You may use a standard 12-lead EKG, but they often use a single lead or 3-lead EKG for children. The nurse needs to remember to assess the patient, not the monitor. Oftentimes people will be freaking out and the attachments are not properly on the patient. So to assess the patient. Chest x-ray provide information on the heart size and pulmonary blood patterns. Echocardiogram involves the use of ultra-high frequency sound waves to produce an image of the heart structure. Oftentimes a CHD can be diagnosed with the use of fetal echocardiogram. Children need to lie quietly, so oftentimes the children are given a mild sedative for the exam. Cardiac catheterization is an imaging study using radiopaque catheters placed in peripheral blood vessels and advanced to the heart to measure pressure and O2 levels in the heart chambers and to visualize heart structures. Nursing care after cardiac catheterization is important. Monitoring of heart through EKG monitor and assessment of blood pressure and vital signs and the dressing where the catheter insertion took place for bleeding is important. Peripheral pulse should also be assessed for the extremity. So that's CMST, which is color, motion, sensitivity, and temperature of the extremity should be assessed, and fluid intake monitor post-catheter. Cardiac MRI is a non-invasive imaging technique, and that's used in the evaluation of the vascular anatomy outside of the heart. Okay. Treatment. Oops, excuse me, skipped a page. So diagnosis, there's also advances in two-dimensional echocardiograms and other non-invasive techniques have decreased the need for diagnostic catheterizations preoperatively. And the definitive diagnosis had been a cardiac catheterization before. So the cardiac catheterization is then often therapeutic. So how do we do treatment? So the goals for heart failure, the goal of treatment is to improve cardiac functioning by increasing contractility and decrease afterload. We want to remove accumulated fluid and sodium. We want to decrease cardiac demands. We want to improve tissue oxygenation and decrease oxygen consumption. Most infants with heart failure are stabilized with medical therapy and then referred for surgical repair. We have become advanced in diagnosing CHD, where oftentimes a defect can be surgically repaired before the onset of heart failure. Non-surgical treatments, improving cardiac function. They will use a drug called digitalis glycosides or digoxin, which improves the contractility of the heart. Angiotensin-converting enzymes or ACE inhibitors, which reduce the afterload on the heart, making it easier for the heart to pump. Beta blockers, which decrease heart rate, blood pressure, and increase vasodilation. They also remove of accumulated fluids using diuretics such as furosemide or chlorothiazide and spironolactone to get rid of excess fluids. In your book, William Wong, see Table 23.3, and it will give more specifics on those particular diuretics. We also might have the children on possible fluid restrictions and possible sodium restrictions. Non-surgical treatments continue. We want to decrease cardiac demands, so we want to provide a neutral thermal environment, not too hot, not too cold. Treat any existing infections. They might administer antibiotics. Reduce the effort with breathing, so we want to place in a semi-Fowler's position. Sedation medication may be needed. Provide rest and decrease stimulation, and improve tissue oxygenation by providing oxygen either via nasocannula or humidified O2. Surgical interventions may include open heart surgery or closed heart procedures, stage procedures, prepare child and family for procedures, and that's definitely a very big nursing responsibilities to help prepare the family and child. Nursing interventions. What are we going to do as nurses? Of course, we're going to monitor vital signs. We're going to manage care to conserve energy, right? So what do? We want to make sure that we're not overwhelming the child. We want to position for best oxygenation. We want to feed every 3 hours. Use gavage as needed. Can increase calories and formula. Monitor fluid balance and keep temperature at a stable level. Children with heart failure have a greater metabolic rate because of their poor cardiac function and increased respiratory rates. Their caloric intake is greater than the average infant. The nurse will seek out ways to increase the child's caloric density of the formula by either adding cornmeal or other additives. And that should be added slowly to avoid diarrhea. So we want to increase the caloric intake. So keeping children with HD healthy. So feeding and growing it must be monitored. Parents should carry a list of child's meds with them. Immunizations must be monitored, and maintaining oral health and support for families. The next slide we have here is steps for CPR. This is a 4-year-old post-op cardiac surgery found unresponsive by a PCT. You quickly assess and verify the child is unresponsive. Help is called. Place the following actions in the correct sequence to perform CPR on a child. This is just a review. You all can look at that and review your CPR. AED, this is another review. What is it? All of you should know what it is. How does it help? Why do most children arrest? AED for children. Where is the AED? So when you are in the schools or when you are in the hospitals, you need to know where those AEDs are. Here is a other NCLEX style question. A child who has been diagnosed with a heart defect is being discharged home to await surgical repair. In the discharge instructions, the nurse educates the parents. 1, to prevent the child from crying. 2, to observe for signs of neurological issues. 3, in cardiopulmonary resuscitation, or 4 to report issues with growth and development. The correct answer is in cardiopulmonary resuscitation. So you'll be doing quite a bit of education with your child as parents. The rationale for this is that parents need to be prepared for emergencies and need to know that they will be able to assist their children. Okay. So let's go on to acquired cardiovascular diseases. These are usually infectious or inflammatory cardiac disorders. The first one we're going to talk about is rheumatic fever. Rheumatic fever are inflammatory diseases that occurs after a group A beta hemolytic streptococcal pharyngitis, so strep throat. It is infrequently seen in the United States, but it is a big problem in third world. It is self-limited. It affects the joints, skin, brain, and serous surfaces and heart. Rheumatic fever usually develops 2 to 3 weeks after onset of infection. It's most frequently seen within 2 weeks, though. And the reason that we see it less frequently in the United States is because we are able to test for strep throat and get proper antibiotics for treatment. Rheumatic heart disease is the most common complication of rheumatic fever. What happens there is there's damage to the valves as a result of rheumatic fever. The mitral valve is the most commonly affected valve. So let's look at a focused assessment. What we'll do as nurses, we're going to monitor vital signs with attention to heart assessment. So that's why it's good to do the 5 heart sounds so that you're able to see where the defect may be occurring. You want to assess for joints, because remember there's joint pain. The joints are affected. Perform a thorough skin exam. Note any nodules or bony prominences. So the joints may be red, swollen. The skin may have erythematous macules with clear center and well-demarcated borders on the trunk and extremities. It's usually non-itchy or non-pruritic. And there may be nodules, non-tender swelling located over bony prominences. Clinical manifestations of rheumatic fever. There might be a carditis, a polyarthritis, an erythema marginatum, subcutaneous nodules, and chorea. Tachycardia, cardiomegaly, and murmurs are possible. Joints can be hot and swollen. The erythema marginatum is a non-pruritic rash on the trunk and extremities that is a macule with a wavy border, and the nodules that are located in the bony prominence might resolve. Chorea is an active movement, uncontrolled active movement. Prevention of RHD and rheumatic fever. Treatment of streptococcal tonsillitis and pharyngitis. So usually they give penicillin G, IM, times 1 day, where they don't usually give that. Most of the times they're giving penicillin or amoxicillin by mouth for 10 days. And they sometimes will give sulfa PO times 10 days. If allergic, they will give erythromycin PO every 10 days. But I know one of my children, would not take the medication at all by mouth, so they did give the IM injection times 1. Treatment of AF. Well, of course, we just talked about primary prevention, which is to give the antibiotics once the strep throat has been diagnosed. You also, if they do contract it, supportive care, bed rest, good nutrition. Again, prophylactic prevention of recurrence in patients with RF without carditis. So they'll give antibiotics for a total of 5 years or until the age of 21. There may be injections of penicillin G every 28 days or oral doses of erythromycin or penicillin, BID, or once a day for sulfadiazine. In patients with rheumatic fever, with carditis, the prophylactic treatment is from 10 years or until age 21 for the prophylactic antibiotics. In patients who have rheumatic heart disease, prophylactics treatment can be until age 40 or even indefinitely. Rheumatic heart disease patients may require surgery for valve repair or replacement. So carditis, just so you know, is an inflammation of the heart, and it can be broken down further. Pericarditis, which is inflammation of the pericardium, myocarditis, which is inflammation of the heart muscle, and endocarditis, which is inflammation of the endocardium, just so you know for terminology's sake. Nursing care, what are we going to do? We're going to prevent. The big thing with prevention, a child has a sore throat, you look in their throat, you see it's red, you see white patches, you want to encourage them to be tested for streptococci. If they are, you want to encourage compliance with medication. Oftentimes when someone has a sore throat, once they've taken the medication for 2 days, they start to feel better, they're no longer contagious, and they may not be compliant. And if they're not compliant, they're not eradicating the bacteria, and therefore complications can occur, and they resulting in a rheumatic fever or rheumatic heart disease. We also want to offer emotional support. We want to provide rest, nutrition, and management of cardiac symptoms if they do come down with the rheumatic fever. NCLEX style question. A 4-year-old child is seen in the clinic for a sore throat and is diagnosed with group A beta hemolytic streptococci. The nurse understands that the risk of developing rheumatic fever is greatest 1, 2 weeks later, 2, prior to the child starting on an antibiotic, 3, with the onset of strep infection, or 4, 4 weeks later. The answer is 2 weeks later. The rationale is rheumatic fever often follows 2 weeks after streptococcal infection, sometimes regardless of treatment. The next disease we're going to be talking about is Kawasaki's disease. Kawasaki's disease is an acute systemic vasculitis of unknown cause. 75% of cases are in children less than 5 years old. It is more common in males. You will also hear it referred to as mucocutaneous lymph node syndrome. This is the leading cause of acquired heart disease in children in developed nations. It is also more prevalent in Japan and in children of Japanese descent, hence the name Kawasaki's disease. There are 3 phases to Kawasaki's disease. There's the acute, which is sudden high fever, unresponsive to antipyretics and antibiotics. Then there's a subacute phase, which is the end of the fever through end of Kawasaki disease clinical signs. And then there's a convalescent, which is clinical signs resolved, but laboratory values not returned to normal. It's completed within normal values 6 to 8 weeks. Kawasaki disease signs: bilateral conjunctival inflammation without exudate. Person may have a strawberry tongue, polymorphous rash, and cervical lymphadenopathy. Blood tests will include complete blood count, which may reveal a normocytic anemia and eventually a thrombocytosis. The erythrocyte sedimation rate, or the ESR, will be elevated. They will have a C-reactive protein elevated, and liver function tests may show evidence of hepatic inflammation and a low serum albumin levels. Other optional tests may include an electrocardiogram, which may show evidence of ventricular dysfunction or occasionally arrhythmia due to myocarditis. An echocardiogram may show subtle coronary artery changes or later true aneurysm. Ultrasound and computerized tomography may show hydrops, enlargement of the gallbladder. Urinalysis may show white blood cells and protein in the urine. A lumbar puncture may show aseptic meningitis. Angiography was historically used to detect coronary artery aneurysms and also remains a gold standard for the detection, but is really used today unless the coronary artery aneurysms have already been detected by echocardiogram. Angiography was historically used, again, like I just said, and temporal artery biopsy. Diagnosis and assessment. The classic diagnosis is based on excluding any other diseases, the presence of at least 5 days of fever, and at least 4 of the 5 classic features. So they will see bilateral non-purulent conjunctivitis, polymorphous skin rashes, abnormalities of lip and oral mucosa, abnormalities of the extremities, and cervical lymphadenopathy. So the rash, the elephant rash in the trunk and groin area in between, and the fingers peeling, and it's a peeling type of skin rash. Treatment of Kawasaki's disease is IV immunoglobulin. They will also use aspirin, 80 to 100 milligrams per kilogram a day for the fever. Then 3 to 5 milligrams per kilogram a day. They also utilize it for antiplatelet treatment. The length of treatment varies. The antiplatelet phase should continue for 6 to 8 weeks. If coronary abnormalities continue, salicylate treatment may continue indefinitely. And an example, I believe, in someone famous that you would know whose child had this was John Travolta's son, who has since passed away, had Kawasaki's disease. He didn't pass away from Kawasaki's disease, but he did suffer from this back when he was a younger child. So complications. During the phase when the fever disappears, the child is at greatest risk of sudden death from coronary vasculitis, combined with markedly elevated platelet count and hypercoagulable state. The care is supportive, even though it is considered an infectious process. The resulting myocarditis is also untreatable with specific meds. The treatment is all supportive. So, pharmacological, again, IV, IgG in Kawasaki's disease, aspirin, like I said. They may give digoxin or lanoxin to improve cardiac function. They may be administering ACE inhibitors to decrease resistance, Lasix to remove accumulated fluid, or spironolactone to remove accumulated fluid as well. Beta-adrenergic blockers in the adult will decrease heart rate, myocardial contractility, and CO, leading to decreased blood pressure and reversal of arrhythmias. So an example of that would be Atenol. That concludes our lecture on cardiac anomalies. If you have any questions, we certainly can answer them in a Zoom. Or if you have any direct questions that you'd like to ask before the Zoom or after, you certainly can email me at jlougrey@hcc.edu. Thanks.